Hi, this is Brian Kim. I'm going to share with you case number 128 in the Best Way to Do Cataract Surgery series. This is a patient who is status post-corneal transplant, specifically a deep anterior lamellar for keratoconus. And this is also a soft lens. The patient has best corrected visual acuity of 20/30, but she also has glare from a PSC cataract. And so she's fairly young. She does have a little bit of haze on the cornea with some vessels, but she has a very strong Bell's reflex. This is her left eye, and you'll be able to see how strong the Bell's reflex is and how I used an Oarlock technique, which is a way to control the eye with no external gripping and grabbing of the eye, minimal contact, minimal trauma to the eye to control the eye with this Oarlock technique. And so you can see this is a patient's left eye. There's a strong Bell's reflex towards the right side of the view. I'm using a cotton tip to help steady the eye and using a corneal marker, which helps me to center and size the rexus. You can see the patient has some corneal vascularization and there's a little bit of haze through this DALK cornea. Despite this, she has pretty good vision, best corrected 20/30 vision, but she's having quite a bit of glare and she does have a PSC cataract, and so that's why we're proceeding with cataract surgery. I'm making my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf to allow me to achieve a self-sealing incision. This is intracameral lidocaine and then epinephrine, and then some dispersive viscoelastic. And so this is the Oarlock technique. This patient's clearly looking all the way up and she won't keep her eye straight for me. She's quite a bit photophobic. So I'm using the cannula as an Oarlock for my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. And then this is important because I want to be able to control the length of my incision because I don't want it to disrupt my corneal transplant incision. So while holding the eye still, I'm using the cannula again to hold the eye in central fashion with this Oarlock technique. The Oarlock technique is an indirect way to control the eye. You're not using forceps to hold the eye. Patients can react to that and then rip the conjunctiva and get a conjunctival laceration, or you can even develop a corneal abrasion when the patient feels the forceps, the teeth of the forceps going into their eye. They can react and do things unpredictably. You can use a Thornton ring, but Thornton rings also have teeth on them. So I've used all those things and I don't really think those are great tools. Using the cannula as an indirect method to hold the eye steady has really given me great success. I don't have any pain with the patient. I'm not getting subconjunctival hemorrhage and no abrasions with this approach. This patient is quite young, and so instead of trying to use the forceps to puncture, I went straight to the cystotome, puncturing, and then doing my rexus with these Haldey-Percar cross-section forceps. Again, thin and low profile, minimal viscoelastic egress, no tendency to radialize, nice opening to the teeth of the forceps, very easy to control the rexus with these forceps. So finish the rexus and then burp some viscoelastic out. I don't need the Oarlock anymore for hydrodissection. So this is the capsular fornix hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, pointed tip down, get a nice wave. Again, this is a soft lens, so it's going to be a little bit of a challenge to get the lens to spin. And I feel pretty good that it's just going to come up here. Irrigate the surface of the eye. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. And again, like I said, it's soft, so when I go ahead and try to remove the lens material here, I'm not actually going to do the double chop or cross chop. I'm just grabbing the edge of the epinuclear material, lifting the lens up with the chopper, protecting the posterior capsule as well as I do that. So in this case, no double chop, cross chop, none of those maneuvers. I'm able to just lift the lens piece up with some vacuum. So that was pretty easy. Go ahead and take the chopper out, push BSS in, Take the phaco tip out and go in with the ironing handpiece. Adjusting the sleeve. Start subincisionally removing the viscoelastic from anterior to posterior. Go ahead and start to peel the cortex from anterior to posterior. Peeled it first on the left side here, and then now in the subincisional area. Just using a foot pedal control, controlling the vacuum as I go into the subincisional space. Again, just using a foot pedal control to very carefully tease the capsule. Again, using a foot pedal control to very carefully tease the cortex from anterior to posterior, not using too strong of a vacuum, let it slowly peel off. There's still some fine material there. Go in with a viscoelastic. Go ahead and start polishing under the rexus edge here. These are the Koch Singer sweep. Right side and left side. Left side and then the right side. Polishing under the rexus edge. You can see how beautifully clean the anterior capsule is when I polish. This is a single piece acrylic lens that's going to go into the capsular bag. Again, this patient had keratoconus. You can see how floppy the cornea is. She has a high myope. All of that kind of goes together. Quickly transition to the INA, go in with irrigation off, activate irrigation, and then making sure the haptics go into the capsular bag. What's interesting is even though this is a nice incision, you can see all this fluid coming out, and it's coming out through the main incision. So again, it just goes to show this keratoconus patients just have abnormal corneas, and you can see the fluid is just kind of coming out, even though it was a nice incision. Polishing underneath the lens, polishing the posterior capsule here, as well as the anterior capsule. Yeah, there's quite a bit of lens material underneath the lens as well on the posterior capsule surface, so I'm just kind of polishing that off. Sometimes it can be rather stubborn. So what I'm doing there is just moving the optic towards me, which creates almost like a protector or a shield as I go more aggressive with the vacuum in the subincisional space there. Just really spending a lot of time polishing within the bag. So I switch to polish mode and then visco mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So again, this is a patient who had a DALK, deep anteromolar keratoplasty for keratoconus. There is some vascularization and haze, but the patient has a best corrected acuity of 20/30. She does have some glare due to a PSC cataract. And so we decided to do cataract surgery. Again, the cataract part was fairly uneventful, and we didn't have to use any real techniques. We just were able to aspirate the lens out. But the neat part of this case was the patient had quite a strong Bell's reflex. This is the left eye, and she kept turning the eye upward towards the right. But I use a cannula as an Oarlock technique to keep the eye nice and straight. Again, other people might use a 0.12 forceps, they might use a Thornton ring, they might use some type of external device to hold the eye, and you see how this patient reacts so much. If you use something like that, she may react even more, may move the eye, cause a laceration of the conjunctiva, corneal abrasion, subconch hemorrhage. And again, may not be that big of a deal, but if there's an easier way, a less traumatic way to hold the eye steady, through the incision, through the paracentesis incision, you just rotate the cannula 90 degrees and it locks the cannula within the incision, and then you can control it any which way you want to. So that's kind of my Oarlock technique as far as controlling the eye in this situation where the patient's not cooperative or there's a strong Bell's reflex. We're able to very easily and controllably finish off the case, doing the capsulotomy, making our incisions. And so, again, this is, in my opinion, so what's interesting is even though I hydrated the roof of the incision quite well, you can see I'm putting the cotton tip at the incision, it's still leaky. And so, again, this is just a testament to this abnormal cornea in this lady, again, with keratoconus. I'm hydrating the edges, and then I'm very carefully hydrating the roof. And again, that looks like it should be pretty good and self-sealing. Let's see. Take another cotton tip, and it's still leaking. So I was like, wow, this is pretty impressive. I feel like this is a good incision. If I have to, I'll go ahead and put a suture, but I'll go ahead and hydrate the roof one more time. We get a new cotton tip, and now it's dry. So good. You can see that silver reflection of the incision, and what that silver reflection is the fact that it is dry there. So again, these are the reasons why I feel like doing cataract surgery this way, it's really minimally invasive, least amount of instruments, least amount of manipulation, no external holding of the eye, which can cause damage. And so using the Oarlock technique, I feel like is another component of why this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.